Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 441 of our pharmacotherapy series, which majors in prostate cancer. This video discusses patient TCW from part 440 of this pharmacotherapy series. TCW's biopsy revealed a Gleason 3+3 which is equal to 6, stage T1C, no suspected nodal or distant metastases, prostate cancer in 3 of 10 cores. So my first question to you reads, based on TCW's prognostic factors, what is TCW's risk group? TCW has stage T1CN0M0 prostate cancer, with a Gleason score of equal to or less than 6 and a prostate-specific antigen less than 10 nanograms per milliliter. With these prognostic factors and with 3 of 10 positive cores, he is considered to have low-risk prostate cancer. TCW consulted with a medical oncologist about his treatment options for low-risk prostate cancer. The oncologist explained that TCW is an overall healthy patient with a long life expectancy and that his prostate cancer is relatively slow-growing. So my next question to you reads, what is TCW's conservative option for the management of his prostate cancer? Studies have aimed to identify those select men who will have a good outcome with a very conservative approach of observation with no immediate, definitive intervention for their cancer. This is because we are now seeing what some call an overtreatment of prostate cancer. Overscreening, as discussed earlier, plays a role, with some models estimating between 23% and 42% of all U.S. screen-detected cancers are being overtreated. This approach of not treating the cancer immediately has subtle distinctions according to differences in patient status. Observation involves no cancer intervention, such as additional biopsies, scans, surgery or treatment, but simply monitors the patient with the plan to only deliver palliative therapy if the patient becomes symptomatic. This is an option for men with low or intermediate risk prostate cancers with a life expectancy of less than 10 years due to concurrent comorbid conditions or diseases that will most likely outcompete their prostate cancer, providing no benefit from treatment. Active surveillance is different from observation, as these men are actively monitored with routine prostate-specific antigen levels and, potentially, digital rectal exams with the expectation of intervention if it looks like the cancer is progressing, with a goal of deferring side effects from treatment without missing the opportunity for cure. For this reason, it is preferred in patients with a life expectancy of less than 20 years and very low-risk prostate cancer, or in patients with a life expectancy greater than 10 years and low-risk prostate cancer. A study of almost 1,000 men with favorable or intermediate risk prostate cancer on active surveillance were followed for a median 6.4 years, ranging from 0.2 to 19.8 years. They were offered treatment if their prostate-specific antigen doubled in less than 3 years, if their Gleason score was higher based on another biopsy, or if they had clinical progression. Of those 993 study participants, 15% had died, but only 15 patients, that is 1.5%, died from prostate cancer. There were an additional 13 patients, that is 1.3%, who developed metastases, but only 4 had died at the time of analysis. At 5, 10, and 15 years, 75.7%, 63.5%, and 55% of patients, respectively, were untreated and continued surveillance. 0.21 In another study of over 5,500 men with low risk and favorable intermediate risk prostate cancer treated with brachytherapy and then active surveillance, 605 men had died, but only 5.6% of those deaths were because of prostate cancer. These studies illustrate the potential to delay therapy in some men without compromising survival. The decision of observation or active surveillance should be made after a full discussion between the patient and the physician of the advantages and disadvantages of this approach. Because TCW has low-risk prostate cancer and an excellent performance status without precluding comorbidities, giving him a long life expectancy that is equal to or longer than 10 years, he would be eligible for active surveillance. He would not be a candidate for observation given his age and long life expectancy. TCW is elected to proceed with active surveillance. His medical oncologist had scheduled appointments and prostate-specific antigen checks every 3 months and digital rectal exams every 6 months. His results are as shown in the table. Pause the video and carefully scrutinize the table before progressing to the next slide. TCW's prostate-specific antigen continued to rise. However, his overall health remained excellent, and he did not have any symptoms from his disease. TCW began to get anxious, and the medical oncologist decided to do a repeat biopsy to reassess the tumor and treatment plan. The results revealed a Gleason 4+3, which is equal to 7 in 4 of 12 cores. So my question to you reads: what are the possible treatment options for TCW? TCW now has T1CN0M0, Gleason 7, prostate-specific antigen 11.7 prostate cancer, placing him into the intermediate risk group. His options for definitive local treatment are radical prostatectomy or EBRT plus ADT with the possibility of adding brachytherapy. Because of the results of several trials investigating the use of ADT with radiation in intermediate-risk patient, EBRT would be given with a short course of 4 to 6 months of ADT. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 442.